Hi, I'm Dr. Suzanne Lippert, and I'm going to be speaking on altered mental status. This is part 1 of 3. In this lecture, I want us to be able to identify and treat the life threats and reversible causes of altered mental status. I want you to remember that a bedside glucose measurement should be obtained on every altered patient. I want to emphasize that altered mental status has many causes, several of which can actually be contributing to an individual patient's clinical picture at one time. And that these patients are sick until proven otherwise. They are also very dynamic and require frequent reevaluation. So let's start with our case. This is a 62-year-old alcoholic man who was brought in by paramedics after he was found holding an empty bottle of alcohol, walking unsteadily, and aggressively yelling, spitting, and throwing objects. By the time he arrives in your emergency department, he is somnolent. This can definitely be described as altered mental status. He has a waxing and waning level of consciousness. He's alternating between being somnolent and aggressive. I think altered mental status as a chief complaint is a perfect illustration of why the emergency medicine approach is so important. We are required in these patients to evaluate, think, and act almost simultaneously. For one, these patients are potentially critically ill. Many of the etiologies in the differential diagnosis are ones that can be life-threatening. So they're potentially critically ill. Second is altered mental status has a very broad differential. And as you can imagine, with our case, this patient is intermittently aggressive and somnolent. And it can be difficult to think through this broad differential in sort of a chaotic environment and interaction with the patient. So the broad differential really requires you to have a systematic approach to your evaluation that allows you to systematically go through all of these potential etiologies and rule them out. And third, the patients are extremely dynamic. By definition, someone who is in delirium often has a waxing and waning mental status, so they require frequent reevaluation. Let's talk about our initial assessment. When we evaluate the patient for the first time, we are really looking for two things: immediate life threats and easily reversible etiologies. So let's talk about our 62-year-old alcoholic. In general, he appears somnolent, alternating with an aggressive yelling and screaming. So again, he's changing even right before you. When you look at his airway, he is able to speak to you. It's patent. There's nothing obstructing his airway, but he does have some slurred speech. He's actually breathing with a normal work of breathing, so he has no retractions, there's no flaring, he's not tripoding or sitting forward, but he does have an increased respiratory rate. And on circulatory exam, you note that he has a very strong, though fast, pulse. He's cool and he's also sweating profusely. On disability, his pupils are equal and reactive, he has equal strength, and his GCS is 12. And finally, on exposure, you notice that there are no skin patches, so no medication patches, no track marks or signs of intravenous drug use, and he has no rashes. So let's talk a little bit more about the Glasgow Coma scale. We use this in trauma, we use it in altered mental status. It gives us a good way to both assess, reassess, and communicate where this person's mental status is. You have a total of 15 points. The lowest score that you can achieve is 3. So someone who is actually dead would receive a score of 3. So let's break it down a little bit. First, you assess eyes for a total of 4 points. So if someone's eyes are closed, they get a 1. If they'll open their eyes when you push on their fingernails or provide a noxious stimuli, they receive a 2. If they open their eyes when you speak to them call out their name, ask them to open their eyes. So opening their eyes to voice, they receive a 3, and that's what our patient was doing. So he has 3 points for eyes. And finally, if they're just opening their eyes spontaneously, then they receive the full 4 points. The second is the verbal score. So there's a total of 5 points on verbal. If the patient is silent and they're not speaking at all, they receive a 1. If they're making sounds that are unintelligible, they receive 2 points. If they actually are speaking words, but they're just individual or nonsensical words, they receive 3. If they have confused speech, so someone who's just rambling off sentences, but they make no sense whatsoever, they receive 4. And that is what our patient received, 4 points for confused speech. And finally, if they are actually coherently speaking, they receive the full 5 points. And then we move on to motor score. There's a total of 6 points for the motor. So for eyes, there are 4. As you move down to verbal, it's 5, and then to motor, it's 6. If the patient's not moving at all, they receive a score of 1. If they have decerebrate posturing, they receive a score of 2. And that's extensor posturing. If they have decorticate posturing, they receive a score of 3. If they are withdrawing to pain, they receive a score of 4. If they have purposeful movements, so if the nurse is putting in an IV and the patient's actually moving to push her away, that's considered a purposeful movement, and that is what our patient was doing. So he received a score of 5. And then if they follow commands, you ask them to hold up 2 fingers on the right hand, then they receive the full points for motor, which is 6. So putting that together, our patient opened his eyes to voice, he had confused speech, and purposeful movements, so he received a score of 12. An essential part of the initial assessment is obviously the vital signs. So as you noted on your circulatory exam, he had a fast rate, and we have his heart rate at 132 beats per minute. He's breathing at 17. His blood pressure is normal at 115/78. His oxygen saturation is also normal on room air at 98%, and his temperature is 37.9. So now we think, this patient has a fast heart rate, he's sweating, he's confused and combative, his heart rate is 132, his respiratory rate is 17, and his Glasgow Coma scale score is 12. Is this patient sick? Most definitely. Even if his vital signs had been much more normal than they are, we should still consider this patient sick until proven otherwise. What this initial assessment really prompts us to do is to act with incredible urgency, given how abnormal his vital signs are and his initial assessment. But even a patient who has normal vital signs who is confused and altered requires immediate attention. So what I like to do is, as I'm going through that initial assessment, I'm always thinking about, well, what things in the airway could actually be causing the patient to be altered, to be confused. So anything that obstructs the airway, obviously, that's what we're looking for in our initial assessment, whether it's a trauma patient or a medical code. Because obstruction is going to lead to hypoxia, and certainly hypoxia will cause altered mental status. And it will often cause agitation. And you can't tolerate hypoxia for very long before you have irreparable damage. So in the airway, I'm always looking for any kind of obstruction that may be leading to hypoxia. As I'm assessing the patient's breathing, I'm looking for any type of hypoventilation. Because what will this cause? It will cause hypercarbia. Again, another cause of altered mental status. So if the patient's not effectively blowing off their CO2, they're going to actually end up with respiratory acidemia, and they'll become increasingly somnolent with hypercarbia. With a circulatory exam, I'm looking for causes of hypoperfusion. So dysrhythmia, which decreases the cardiac output, and shock. So any type of shock. Distributive shock, like septic shock, cardiogenic shock, obstructive shock from a pulmonary embolism, or hypovolemic shock. All of these will lead to hyperperfusion of of the brain, and altered mental status. So on disability exam, remember we are also looking for reversible causes of altered mental status. So hypoglycemia. This can cause confusion in and of itself. It can also cause seizures. So you may see a patient who's actively seizing. You may see a patient who's in the post-ictal phase, or just a patient who's confused. Exposure. I always look for medical patches, particularly in a somnolent patient. If the patient has any kind of narcotic patch on, they actually may be hypoventilating from an overdose of narcotics. So it's essential to really look over the patient and determine if they have any medical patches, if they have any rashes, or anything else that may give you clues to either a life-threatening illness or an easily reversible cause. Right, so now we need to act, clearly. When we went through our initial evaluation of our patient, we found that he had an open airway. It was patent, he was speaking. He did have adequate oxygenation, but given that we're still in the initial stages of our assessment, it is fine to actually provide oxygen to this patient. He, of course, does not require bag mask ventilation, as he's breathing comfortably, though at an increased rate. We place him on a cardiac monitor and find that he's in a sinus rhythm with a heart rate of 132. There's no indication for defibrillation or CPR at this point, and he has no evidence of bleeding on your initial assessment. He does have this fast heart rate of 132, so we place an IV and we begin volume resuscitation with normal saline. We then also perform a point of care glucose and find that he has a glucose of 46. We immediately provide D50 as well as thiamine as soon as it is available. So let's stop here because I really want to emphasize that we need to check a point of care glucose on every altered patient. We also need to provide dextrose immediately for hypoglycemia. And in our alcoholic or malnourished patients, we want to provide thiamine 100 milligrams IV, but we do not delay the administration of dextrose. So again, it is important to provide the thiamine, and that's because of the risk of worsening or precipitating Wernicke's encephalopathy in these patients who may be deficient in thiamine. But we do not want to delay dextrose. So let's review our case. We have stabilized this patient to some degree. We have a 62-year-old alcoholic man who was holding an empty bottle of alcohol, walking unsteadily, and then he's been alternating between being combative and somnolent. On our initial assessment, we found that he had hypoglycemia to 46, so we immediately administered D50. And he actually becomes more alert, his diaphoresis resolves, and his glucose on a subsequent check has gone up to 120. The patient's Glasgow Coma score at this point is 14. So he's again improved from 12 when we initially assessed him to 14. He still has 1 point off of the verbal score for confused speech. So he's improved, but it's still not normal. Similarly, his heart rate has significantly improved from 135 down to 122, but he's still quite tachycardic. And his respiratory rate is about the same. He was 17 on our initial assessment, and he's now breathing at a rate of 20. So, are we finished? Certainly not, right? Remember, we cannot ignore abnormal vital signs, and altered mental status is most often multifactorial. So we need to find and treat the underlying causes. We've identified at least one cause so far, hypoglycemia, but we are certainly not finished. So we return to our emergency medicine approach. It is now time to reevaluate, to again think through the differential, and to act by performing diagnostic tests.